Imagine a condition where your chest caves in, not just affecting your appearance but also your breathing and heart function. That's pectus excavatum, and it's more common than you might think. But here's where it gets controversial. While surgical treatments like the Ravitch and Nuss procedures are effective, recurrence is a real concern. And this is the part most people miss: what happens when the condition comes back, especially after a Ravitch procedure with a retained strut. We're about to dive into two fascinating case studies that tackle this exact scenario, showcasing the modified Nuss procedure as a potential solution. But before we proceed, let's ask ourselves, is the Nuss procedure always the best option for recurrent cases, or are there hidden risks and controversies we should consider? Pectus excavatum, PE, is a congenital chest wall deformity that often requires surgical intervention, such as the Ravitch or Nuss procedures. While both methods are effective, recurrence remains a challenge. In this article, we explore two cases of adult patients who experience recurrent PE after undergoing the Ravitch procedure during childhood, with retained struts identified over 15 years later. These patients were successfully treated using the modified Nuss procedure, a minimally invasive approach that has gained prominence for its effectiveness in complex cases. Case 1 involves a 26-year-old woman who presented with progressive shortness of breath and palpitations. Her medical history included a modified Ravitch procedure performed 20 years prior, with a retained stainless steel strut. Preoperative imaging revealed severe chest wall deformities, cardiac compression, and a Holler index of 11.87. The modified Nuss procedure was performed under thoracoscopic guidance, with meticulous planning to address the retained strut. Postoperatively, the patient experienced significant improvement in cardiac function and quality of life. Case 2 features a 29-year-old man with persistent chest discomfort and dyspnea, who had undergone a modified Ravitch procedure 15 years earlier. His evaluation showed a depressed anterior chest wall, a Holler index of 4.0, and a retained strut. The modified Nuss procedure was executed with thoracoscopic assistance, ensuring precise bar placement and strut removal. The patient's symptoms improved markedly post-surgery. These cases highlight the feasibility of the modified Nuss procedure in managing recurrent PE, even in the presence of retained hardware. However, the approach is not without debate. Some argue that the presence of retained struts increases surgical complexity and risks, while others question the long-term outcomes of this method. Additionally, the optimal timing for strut removal and the potential for hardware-related complications remain contentious issues. In conclusion, the modified Nuss procedure offers a promising solution for recurrent PE after the Ravitch procedure, but it raises important questions about surgical timing, hardware management, and long-term efficacy. As we continue to refine these techniques, further research is essential to address these controversies and optimize patient outcomes. What are your thoughts on the balance between surgical innovation and long-term safety in treating recurrent pectus excavatum? Share your perspective in the comments below.